Thank you, Dr. Tanvi. Now I invite Dr. Suhas HALDIPURKAR sir to speak on his topic. He does not need any introduction. He is one of the greatest phaco teachers who has taught surgeons across the globe. I am fortunate to have learned phaco from him. His topic for the day is what new things I do in the operation theatre for last 1 year. So this would be a video-based presentation. So I request HALDIPURKAR sir to take over and speak.
Thank you, Dr. Vijay. Well, this course, in the first place, was, thought of 2 years back, where we wanted to, because we had time, we thought we'll come out with what are the new things that we learned. But since the title has continued, but what I thought in this particular talk of mine is to bring about to you or share with you some of the very simple steps that I added in my day-to-day cataract surgery with very specific reasons, and I achieved all that. And I was very happy I have added those, and they definitely make my surgical results more precise and better. Now, first of all, I changed my side ports from bimanual to coaxial. So naturally, my side port from 1.1, I brought it down to 0.8 stab. Now you'll wonder why 0.8 stab? Because when you use your bimanual and you use your chopper comes in different sizes. Some are bulky, some are very narrow. And when you use a narrow one, there's a lot of leakage happening. There are machines which can take care of that leakage because those machines are so very sensitive. But most of the machines are not even aware that so much of fluid is going out from the side port. And that tends to make your chamber shallow. It's not working. Hello? It's not working. So this is a stab incision of 0.8, and I stopped using forceps, and I use a soft stick simply because, I don't want to have any subconjunctival hemorrhage there. Then I started making a groove before entering so that my external lip was more clean and there were no frayed edges for my external lip. Then I changed my style of doing my wound closure. And this is where what you noticed me doing was after I hydrated the floor of my wound, I'll just go through it again. See, that is all the amount of hydration I do. Here I'm trying to press the lens back because very often, see the hydration that I do is just hydrate the floor and that just seals it. So you don't have the cornea becoming white because of wound hydration. And because the side port is very narrow, very often I'm sure you have noticed when you have really made your chamber firm, the wound is sealed well, but the AC still looks shallow because the lens is still not back into the original position of to be at the posterior capsule. At such times, if you go with your side port, with a spatula through the side port and press on the lens, and you can literally see it pushing back and the AC deepens, and then you again rehydrate the floor and it gives you a very deep chamber. One thing that I picked from these webinars is from one surgeon who made it a point to rotate the nucleus clockwise and anti-clockwise 3 to 4 times. And I practice it, and I have realized, I have seen some of the benefits of getting your cortical aspiration easy and complete. With regards to bimanual IA, I changed and modified it. I'm very conscious about my side port, the wounds getting disfigured. So I don't cross the midline. If I'm using bimanual with irrigation on the left hand, now irrigation is from the right. What I do is, I just stay on this side of the midline. I'm very, very cautious. So by doing that, my side ports are preserved so well that after I put the lens, see the amount of hydration that I need to do. You just inject a drop or two, and your eye is firm. And then I go with the antibiotic. And to inject antibiotic, I stay outside. I don't even push my thing in, and the eyeball is firm. I have stopped doing wound hydration in last 2-3 years. And it's possible if you preserve your side ports. Normally, we do our implantation under viscoelastic. Some do it under hydration. The reason for doing it under hydration is that you don't need to spend time doing your visco removal. So I decided to go for a hybrid lens implantation, where what I do is, I inject very little amount of visco in the eye. Now I have just flushed it. Very little visco. And that's all it is. I go with the 2 cc, go to the extreme end, inject hydro to fill the bag. So while doing that, some of the visco has come out. And here through my side port, the fluid does not leak because it's a 0.8 side port. After you have implanted your lens, because you have a triplanar wound, even that doesn't leak. And the small amount of visco that you have put is enough for you to get your lens inside. Now, under the lens, normally there will be a lot of visco remaining, and you need to spend a lot of time washing it out. Here you don't need to do that because the amount of visco that's there is not much. But as a customer, I always prefer to go under the lens, because one of the reasons for early PCO or fibrotic PCO is some of the muck that stays underneath. Even if there's no obviously much of viscoelastic, it's always better to flush under the lens. And then, now this is how all of us, place our toric lens in the desired position. Here you don't see the mark because it is done under Varion, markerless. So I'm seeing the marks, but the video doesn't capture it. But it is possible. But sometimes this easy step is not possible. Your IA is not able to rotate the lens to the desired position. See again. So what it does is, it just hydrates the wound, and quickly the two lips close, and you have a firm eyeball. When it comes to toric implantation, if my IA cannula is not able to get the lens in the desired position, after I hydrate my wound, I make another stab, which is around 0.5, just a small entry, just enough for my Sinski to go in. So the Sinski, once it is in, there's no fluid leaking out. So the AC remains formed all the time, and I can take my toric to whatever axis it needs to go, and the AC never collapses, which you can never do through a side port of 1.1, because the moment you go with your instrument, the AC collapses and you have to refill it. Here, till I get my lens in the desired axis, the AC remains formed, and once the lens has reached the marks, these marks I had to specially make so that in the video one can see them. Till now, the AC is formed, and I have my lens in the desired position. And then, as a completion, I again inject some fluid, meaning I do floor hydration. I check whether the eyeball is firm. It is not. So a little bit of fluid. And then I take my spatula and press the lens back, because I realized that lens was not fully placed posteriorly. And especially for a toric lens, sometimes you know the lens is in the exact axis, but that axis of the lens and the two markers on your marker lens, they are parallel to each other, and there's a bit of parallax. At such times, if you go through the side port and press the lens back, sometimes that parallax closes and the lens is more aligned with the Varion markers. Now, this is a very common picture with most of us, especially when you have a floppy iris. And what we normally do is, you push it back with the irrigation stopped, and then the second thing you do is hydrate the wound. Sometimes it works. And the third thing you do is start irrigation only when you reach in the middle, but sometimes it doesn't even work that way. So here what I do now, so this is another step that we do, that we inject some visco near the wound and hope to keep the iris back there and work, but even there sometimes it doesn't work. And the iris just refuses to behave properly. So a small tip that I can share with you is go with the spatula, keep the spatula there, then go with your irrigation, and now the iris cannot misbehave. Now these are tips which I'm sure would help you. This is something I have been doing for quite some time. Whenever I have a posterior polar cataract, what I do is called in situ four quadrant. You can do it better if you have a bent tip. Here you have not done hydrodissection, so your nucleus cannot be rotated, but you can certainly do your four quadrant in this style, and it's easily possible. You can deepen your trenches, and once one particular quadrant crack is achieved, you can go and do the further cracks in this manner. For example, in cases where nucleus rotation cannot be achieved, even if it is not a posterior polar cataract, this technique works for me all the time. And the indication for doing this, using this technique, is non-rotation of the nucleus. And what is left is just the posterior plaque. Finally, go with your chopper and lift it up. And finally, what you're left is the posterior plaque. So this was another simple step I thought I would share with you. And unlike what Dr. Chitra said, LRI is definitely an integral part of every cataract surgeon. We do toric practice, and we also have patients who would benefit from a cylindrical correction, and for monetary reasons they cannot go for, and for them LRI is an option. To me, LRI is done in the following manner. I complete my case, do the hydration in the way I have shown you. Then, with the help of my markerless marker system, first I mark the steep axis. Then, by NAPA program, I assess the size of the arcuate arc. Then measure the depth of the peripheral cornea, set my diamond knife, and do your LRI in the desired steep axis, and it works well. And it is something I'm sure most of you do, but if you do not, please start with it. And few LRI pearls, that's my last slide. LRIs can produce a hyperopic shift of about 0.2 diopters, so it is advisable to choose a higher powered lens than is suggested by the IOL power calculation. Any bleeding from corneal neovascularization can blunt the desired flattening effect of LRI. A slight undercorrection can instantaneously be adjusted by creating a new LRI central to the existing one or lengthening the existing LRI. If an overcorrection occurs, wait for 2 to 3 months before any action. Thank you so much. If you have any questions, we'll be very happy to answer. Yeah.
Hello, sir. Is it working? Yeah. Okay, sir, as always, very inspiring surgical videos. I just had one question regarding the in situ 4-quadrant technique which you showed. Do you think that the same technique can be done with phaco equipment which do not have either torsional or elliptical phaco?
I do it with my Earthly, which is a straight and a conventional.
Okay, only simple conventional
you
longitudinal
can.
phaco.
Yeah. Just the bent tip makes it more efficient, especially for the upper cracks, but all the 3 cracks, it's possible. And then the trick is, after you've done that, you take a chopper, go sweep the upper nucleus and just nudge it down, and then crack.